So I'm going to talk about radiation, primarily radiation. The topic says bladder sparing, but of course we're talking primarily about radiation-based therapy here. The question is, should we be doing this more? Lots of disclosures, none of them really relevant to this talk. And I would give an emphatic yes to this question. We should be doing more bladder-sparing regimens for muscle-invasive bladder cancer. So if we look at bladder sparing, we do have different modalities at our disposal. We have surgery, radiation, or systemic therapy that we can use. When we're talking surgery and bladder sparing, there are rare patients where we would do a radical TURBT alone. I must say in 15 years of practice, I've done this maybe once, so I'm not a big fan of that for muscle-invasive disease. There are things on the horizon that we talk about, for example, the gemcitabine-loaded pretzel, the TAR-200, which is targeting bladder preservation, which I think is very interesting and will await clinical trial results. And of course, there are some patients suitable for partial cystectomy. Radiation is where I'm going to spend most of my time, whether it's radiation alone or trimodal therapy, including systemic chemotherapy. And then another sort of niche setting is this idea of giving neoadjuvant chemotherapy but preserving the bladder in patients who have an extraordinary response, especially if they have markers of sensitivity such as DNA damage repair gene alterations, and that's also something under evolution. Now, if we're talking about radiation therapy specifically, there are really different degrees of radiation. I don't know if the terminology is universal, but certainly we use palliative radiation in some patients. Our radiation oncologists talk about high-grade palliation, where a patient may be too frail, too elderly to get full-dose radical radiation, but you want to do some damage control, so to speak, of the tumor. You can do radical radiation where you're giving a curative intent dose of radiation without concomitant chemotherapy, which should be an exception. One of the points I'd like to highlight is we can give other chemos other than cisplatin in these patients if they're not eligible. And of course, the standard of care is trimodal therapy, where we're including the concomitant chemotherapy. So just to highlight the trimodality part of it, so the TURBT is critical at the beginning. We think that it's important to maximally TUR, plus we want to rule out diffuse carcinoma in situ. We'll come back to both of those 2 points. External beam radiation, of course, is the central part of it. I'm going to highlight in the talk the use of fiducial markers. And then the concurrent chemotherapy that sensitizes the tumor to the effect of the radiation. If we look at radiation alone, it is clearly inferior to radical cystectomy. If we're looking at trimodal therapy versus radical cystectomy, that's where we get potential equivalence of outcomes. From a urologic perspective, I'd highlight the need for ongoing cystoscopic surveillance as well as the potential for salvage cystectomy, which is really built into the algorithm, plus any additional TURBTs that come along the way. So trimodal therapy really integrates the urologists at all levels. Now, we had a meeting just as COVID was hitting. It was the Johns Hopkins AUA bladder cancer meeting, all about bladder preservation, trimodal therapy. And Jason Estafiou, who's the next generation, Bill Shipley from MGH, pushing the agenda on bladder preservation, had these 10 points that he made in a talk justifying trimodal therapy. I was giving a summary on it the next day, and I made it into Jason's 10 commandments on trimodal therapy, and I think it summarizes nicely some of the key points. So we do have to remember, as urologists, especially medical oncologists, typically look a little bit further than we do. We only see urology, but organ preservation is commonplace in other organ sites where maybe surgery used to be common. I think especially head and neck and anal cancer, for example, radiation has taken on a more important role. So there's no reason why we cannot adapt in the bladder world as well. We know that cystectomy is a morbid procedure with a high rate of complications, readmissions. There is a real mortality rate. There's also long-term impact on quality of life. We have to remember, a point that I'm going to highlight is that 50% of patients do not receive curative intent treatment for muscle-invasive bladder cancer, not only in the United States, also in Canada, also in some European countries. So that is a real problem. If we can treat more patients, we will potentially have better outcomes without any other change in what we do. Number 4, I highlighted that includes surgery. Number 5, long-term outcomes are excellent and are comparable to radical cystectomy if patients are well selected, and we'll come back to this, of course. That's one of the key points that we get hung up on. Concurrent chemo is important. Long-term toxicity is acceptable. I'm not going to spend much time on that, but the data we have is that patients preserve well-functioning bladders and have excellent quality of life. The need for a cystectomy due to side effects is there. It's not zero, but it's not nearly as bad as a lot of urologists would like to think. Patients will have superficial recurrences. Those can be managed as de novo disease, just like we would any other superficial disease, although I think we do have a lower threshold to perform cystectomy if a patient has a high-grade recurrence after radiation. It's supported by the guidelines, and biomarkers may help at some point. So let's talk about patient selection. So the optimal patient is clinical T2 or T3, has a tumor size less than 5 centimeters, no or at least no multifocal extensive carcinoma in situ, no hydronephrosis, no lymphadenopathy, is eligible for concurrent chemo, and of course has to have a bladder worth sparing, so to speak, so adequate bladder capacity and function. The carcinoma in situ question comes up a lot. I think you will hear a lot in multidisciplinary conferences or talking to urologic colleagues, the patient has carcinoma in situ, he or she is not eligible for radiation, but I think we have to be careful there. A little bit of carcinoma in situ adjacent to a muscle-invasive tumor is not a contraindication. We just want to avoid it in patients with extensive carcinoma in situ, where we know after trimodal therapy they are still going to have extensive carcinoma in situ, so we haven't fixed the problem in that case. I highlighted one center that showed a difference on the last slide. If we look at other centers, it's very mixed whether carcinoma in situ actually impacts outcomes or not. The expert consensus, as I just said, is that extensive is a problem, focal is not, and consider random biopsies at the time of TUR to help decide. Now, often these patients, at the time of TUR, you don't know that the patient's getting up with trimodal therapy, so you may not have done it, and in worst case scenario, you might have to go back and do it if there's any suspicion, especially if you're doing a re-TUR to ensure maximal resection. So now we always talk about the optimal criteria, but it doesn't mean that we cannot do trimodal therapy for patients who are not optimal. I think we have to bear that in mind. The optimal patients also do particularly well with cystectomy, but it doesn't mean that we don't do cystectomy in non-optimal patients. So we just have to be careful with what we're doing. We have to recognize the limits, and if a patient is otherwise not going to get treated, of course, trimodal therapy is an excellent option for the non-optimal patients. And so the point I've already made, that we really need to focus on delivering more therapy of any sort rather than debating too much about what type of therapy it should be. Some practical points of delivery of trimodal therapy. I would say first that we often don't talk about this, but I find in my own environment, I'm the strongest advocate of trimodal therapy because we don't necessarily have a lot of expertise. We're developing the expertise, but our medical oncologists and radiation oncologists actually are not used to doing trimodal therapy for bladder cancer. And there are deep-seated biases that if a patient can have surgery, they should have surgery. And so I think you have to get over those biases, and then you have to develop the expertise within your team to deliver optimal care. And there are some nuances. So these are some of the things I want to talk about. The completeness of the TURBT, is it really important? The use of fiducial markers. Just one slide on the schedule, and then also a couple of slides on selection of chemotherapy. So we always say that you need a complete TUR, but of course it's always retrospective data, and there's a real risk of bias. The smaller, lower stage tumor is the one that you can do a complete TUR on. The bulkier, higher stage tumor is the one that you're not going to do a complete TUR on. So of course, there's to some degree it's a surrogate for clinical stage, but I think the consensus is it's not only that, and that the debulking may actually be important, whether it's because in some patients you'll actually get a complete response just from the TUR, and maybe the radiation's not actually doing anything. There's this idea that if the tumor is smaller, there's less hypoxia, so there'll be less resistance to radiation. And then there's also the idea that there'll be less hematuria or other problems that might actually lead to interruptions in treatment. So we do strive for a complete TUR. This is data from the Mass General, sort of larger cohort, 343 patients. And you can see that complete TUR versus incomplete TUR, there are differences with respect to overall survival, disease-specific survival, and proportion undergoing cystectomy. I'm just going to jump over that one. So fiducial markers, I think, is interesting. There's not a lot of evidence about this, but it's very easy to do. The issue is that, of course, the bladder moves from day to day. It moves depending on state of fullness of the bladder, but also the nearby bowel. And so there's a risk of really irradiating something different every day. And fiducials can help the radiation oncologists set it up every day where they're doing image-guided radiation, essentially. This is just one study that shows that three different radiologists planning target volume with or without fiducials. And the overlap in the fields of radiation is quite variable, and that variability is less if you use fiducial markers. So that's fairly low-level evidence, but there's some evidence that it might be beneficial. And so this is how we do it. We do it through a flexible cystoscope, and I should say that we've adopted this based on what they do at the University of Toronto, where they do a lot more trimodal therapy. But we have a 27-gauge needle that is the same as a Botox needle. We can do this in the clinic through a flexible cystoscope with a awake patient. And we take Lipiodol, which is just rather viscous fluid, but easily injected. We inject less than 1 cc, usually in 4 quadrants around the tumor bed, around the scar, essentially. And it just makes it easier for the radiation oncologist. You can see here at the top, no Lipiodol. They have to guess where the tumor was ultimately, and you know that the urologist's description is not very accurate, and the radiologist's description is not particularly accurate. We often don't see much on CT, so I think there's a real potential advantage here, and in this case, you can see fiducial marking around the tumor in the bottom.
How long will it stay there?
Weeks, so longer than it needs to. Not that it gets in the way, but... And I think we're all familiar with these two options for delivery. The Mass General group has popularized this restaging cystoscopy in the middle of the radiation, and I think they've done it with the intent of making it more attractive to the urologist. It's a safety thing. If we don't have a complete response early, we want to change gears and go on to surgery. In general, of course, it doesn't make sense to stop radiation. It's so important from a radiation biology point of view to keep things going. So the alternative, I would say European model is to do the radiation continuously and reevaluate after completion. And Erlangen is a group in Germany that's done a lot of this and publishes a lot, and that's their model on the right there. I'd say we do mostly the Erlangen or European model in Canada. So I've highlighted that concurrent chemo is critical. The best evidence for this comes from a trial in the UK, the BC 2001 trial, that was a phase 3 randomized trial of 360 patients at 45 centers with or without 5-FU and mitomycin. So a different chemo than we usually see on this side of the Atlantic. But a chemo that's used frequently for example, anal or head and neck cancer. And there was a clear difference with respect to the different survival outcomes. Here I'm showing the local regional disease-free survival, chemoradiotherapy versus radiotherapy alone. So this is without question standard of care. In the US and Canada, it's usually cisplatin as first choice chemo, a much lower dose, of course, than you would give for neoadjuvant chemotherapy. But we have to remember the alternatives, and I struggle with this in our own environment, where if a patient's not cisplatin eligible, and for some reason they're never at 5-FU mitomycin eligible at the same time, then the answer is, well, there's no evidence for anything else, it's going to be radiation alone. And I think that is potentially a mistake, and I think we can use gemcitabine. There is evidence for that. There's phase 3 data from the UK, again, in carbamazine and nicotinamide, which are anti-hypoxia agents. I don't think that those are approved or used anywhere in North America, but in principle they could be. So what is the role of neoadjuvant chemotherapy? This is again a controversial topic that the answer to this depends on where you are to some degree. So neoadjuvant chemo prior to trimodal therapy in the US has been poo-pooed due to one negative trial, an RTOG trial, 8903, that addressed this question very specifically, neoadjuvant chemo, yes, no, ahead of chemoradiation. There were 2 cycles of CMV. It closed early with only 91 patients completing treatment. There was no growth factor support, so there was a lot of neutropenia and sepsis, and really it was severely underpowered to detect the endpoint it wanted to detect. So what I'm suggesting is it had major flaws, and it should not be the one trial that we cite to say no to neoadjuvant chemotherapy. On the other hand, we have another large British trial, almost 1,000 patients, neoadjuvant chemotherapy, again CMV, this was 3 cycles, prior to either surgery or chemoradiation. This, I'm not sure if Parminder showed this in his slides or not, but this is the European equivalent to the Grossman trial, but it included radiation or chemoradiation. And you can see that about 50-50 patients had cystectomy versus radiation. There was a benefit to neoadjuvant chemotherapy in this study, and that benefit did not depend on whether you had surgery or radiation. So this is level 1 evidence suggesting that neoadjuvant chemotherapy should be given before trimodal therapy, and it makes sense if you're thinking of what you're trying to achieve with the neoadjuvant chemotherapy, which is a sterilization of micrometastatic disease. One other thing that I observe, I'm not sure if people observe it at other places, but this idea that if you start, so in Toronto, they will generally, in a multidisciplinary setting, they will start with diagnosis of muscle-invasive bladder cancer, start neoadjuvant chemotherapy, and sometime along the way decide on surgery versus radiation. And I think the potential trend there is that you have an excellent response to chemo. You're more likely to choose trimodal therapy and preserve your bladder, and if you don't, you're more likely to get cystectomy. So I think that we see that, whether it's good or bad, we'll have to see, but I sort of observe that happening. In the context of systemic therapy, I also just wanted to mention that there are 3 different trials ongoing with either concomitant or adjuvant immunotherapy with trimodal therapy, a very attractive concept. And the big one on the left is one that Parminder's leading through SWOG and NRG and the other cooperative groups. And I think it's accruing very well, and it will give us important answers. So what about outcomes? This is sort of where everybody always looks at is from a survival point of view, is one better than the other? And it's still really difficult to answer that question. There are a lot of problems with looking at retrospective comparisons of different patient populations. One big issue is radiation is always based on clinical staging, surgery is often based on pathologic staging, and those two just do not correlate very well, as we know. And so if we're looking at at population level data, which is actually in the blue boxes on the right, you often end up with the really the older patients with more medical problems getting radiation and the younger, fitter patients getting cystectomy, and then you conclude that cystectomy is better. And you can do that over and over and over again, and it doesn't change the fact that there's massive bias in who's getting what. On the other hand, if you look at the more single institutional or trial level data, the trimodal therapy patients are more often to be clinical trial patients and are more highly selected than the large institutional or single or multi-institutional series where it's all comers. And so there's a potential bias that would give better outcomes to trimodal therapy or similar outcomes, but a more select patient population. This is a table that I think we often look at from a review paper back in 2013, but it shows big cystectomy series in the U.S. Versus big radiation series. Again, a lot of it trial series in the radiation, and the outcomes are very similar with respect to 5 and 10-year outcomes. So we can't really say that one is better than the other based on that, but the evidence is quite, the studies are very different. There was one prospective randomized controlled trial that in the UK again, which unfortunately closed early due to poor accrual. It sort of failed to meet the feasibility endpoint because there's a lack of equipoise amongst the investigators. Some of the best data we have comes from Toronto. There has been a paper published from Toronto. This is sort of an updated look of Toronto plus USC plus Boston, where they've done a multi-institutional matched comparison between surgery and radiation. The prior publication in JCO from Girish Kulkarni was just the Toronto data. And I think this is interesting. So it's retrospective, of course. 700 patients with muscle-invasive disease from these centers, node negative. They were all deemed, in retrospect, to be eligible for either surgery or radiation. They're treated at one of the three major centers over a 12-year period. They had some exclusions, so extensive CIS, presence of hydronephrosis, and size greater than 7 centimeters, pretty big. They did some propensity matching, which I won't get into. I don't necessarily understand it. They did a 3 to 1 matching, and actually the final sample size ends up being bigger than the 703, but you end up with 3 cystectomy for 1 radiation patients, and you can see there that they controlled for a lot of relevant covariates. And their conclusion is that there's no real difference, but it's interesting that trimodal therapy, the line for trimodal therapy is always above the line for cystectomy, whether it's distant failure-free survival, overall survival, or an adjusted disease-specific survival. So after propensity matching, outcomes are similar. And I think this is ultimately the best we can do with the data that we have if we're not going to have a randomized trial. So my take, just to summarize my take on the survival outcomes, is that the bulk of the literature suggests equivalent outcomes for the optimal patient. So for sure, if you have a patient who meets the optimal criteria, I think we need to be talking about both radiation and surgery and letting the patient decide. But I do think that the literature favors trimodal therapy in this regard, and that there is a potential based on just the low number of patients out there and where they're coming from, meaning what kind of study, that surgery might be better, but we don't really know. So there's uncertainty about the equivalence, and we just have a lot more experience with surgery. And it comes down to shared decision-making, as with so many other things. I think that as urologists, we can't just say surgery is better, therefore I'm not going to talk to my patient about it. We need to talk to the patient about it. And even if you express the uncertainty that surgery might be a little bit better, it's going to be a small difference. And the patient may really decide they would preserve to take that risk and keep their bladder, because it is a big difference with respect to keeping their bladder. So my take-home messages are, yes, we need to be offering trimodal therapy more often to patients with muscle-invasive bladder cancer, especially optimal patients, but also non-optimal. I do think that we need to be considering neoadjuvant chemo ahead of trimodal therapy, and I'd be interested to hear what our medical oncologists think of that. And we need to be considering alternative chemotherapy in patients who are cisplatin ineligible.